So good morning, everyone, and thank you so much for having us to your grand rounds and for your interest in the topic of debriefing in your clinical environment. And Jenny and I will be talking with you, interacting with you, demonstrating with you about something we're quite passionate about, which is Circle Up, a debriefing method for the clinical environment. I been teaching with Jenny for over a decade. She's my teacher and mentor and colleague and friend. I was the senior director at the Institute, which is our faculty development and training arm at the Center for Medical Simulation. And until last month, when I took on a new role as the Director of Innovation and Education at the Boston Medical Center. So I switched my practice from Brigham and Women's Hospital, where I had been for the last 5 years, and took on a new role. So I'm just on the other side of town now and remain quite connected at CMS as a senior fellow, teaching in all our programs and doing scholarly work alongside Jenny, which is a pleasure. So glad to be here.
Hello, everybody. I'll just add a little bit to Shayla's wonderful introduction. Thank you, Shayla, so you can decide whether to believe anything I say today. I'm actually an organizational behavior scholar by training, but for the last 20 years, I've been really interested in how do we learn in healthcare and what are called other high hazard industries. And what I hope to connect with you about today is I really see learning from everyday clinical practice as a career, lifelong, people growing machine. Disturbances, difficulties, joyful moments are all the same in things that making us better and making us better at getting better if we use them that way. And so my mission at the Center for Medical Simulation for maybe the last 15 years has been, how do we use that across the Harvard teaching hospitals to help all of us perform better in teams and take even better care of our patients. So, well, thank you so much for having me and appreciate the welcome.
So you'll see that Jenny and I will be going back and forth and team teaching here. When we get excited and we're both talking, we're not interrupting each other. We're just adding to each other's ideas. I work with her holding this basic assumption, and I do with clinicians and participants that I believe everyone's participating is intelligent, capable, trying to do their best, wants to improve even when it doesn't quite feel exactly as I was expecting it. And I hope that you can keep that in mind as possible attitude or mindset or philosophy towards what you're bringing to work and also how you're experiencing our presentation today. Formally, at the end of today, I'm hoping you can describe debriefing in the emergency department, what it looks like, feels like, what it means to you, the awesome and important skill of getting it started, just initiating a team debriefing. I will be really satisfied if we are all at least ready to do that or thinking about being ready to do that. And some of the theoretical and motivational underpinnings, which are around recognizing how important the interactions are on team culture. And I'm talking both about when we're getting down and dirty and working together, and also when we're reflecting and processing.
Damien, can I build on that last one for a second?
Please.
Just to enact that in our conversation today, everyone, Damien and I will be slightly interdependent with you. There's going to be some moments where we'll ask you to either speak to us directly if you prefer, or to text us in the chat. And one of those moments is coming up shortly. Well, we'll be asking you to share your point of view in the chat. So if you can be ready for that, that would be fantastic.
And so just to give you a little roadmap here, we've got a tiny bit of background and some definitions just so that we make sure that we're all talking about the same abstract concepts and having a good idea of what we mean, and essentially sharing some of our current mental models on the topic. We have a video-based example so we could really see it concretely, give us something to talk about. And then a bit of a presentation around how culture and conversation interact with each other, blending in theory and practice, and some practical advice on how to initiate a clinical debriefing and a few other tips. And since we've been so grateful to get a few extra minutes, I hope we can at the end have a few reflections and comments, because ultimately Jenny and I are interested in not just what we're saying, but how it's landing on you and what impact these words will have. So let's get to it. I think everybody knows what this is. This has been a really challenging couple of years for me personally and for the field. The global COVID-19 pandemic it's really changed everything, and there's people behind those stats. It's not just the numbers. As emergency physicians, we felt the burden both at work and at home, and we know that there are a ton of challenges, and that's where we wanted to get started. Just asking you today, 10/28/21, what do you see as really the challenges and opportunities in our clinical setting, in the everyday, that are really, making an impact on your work and life? And that's how I'm thinking about it, Jenny. If you have a different way you want to put it out there.
No, that's lovely. And if you just click, Damien, the question will be also visible to them. Folks, we'd love to hear from you in the chat or verbally, if that's easier for you if you're driving. What are the opportunities and necessities for you at this moment?
I'm hearing medical misinformation. I can't.
Yep, and I heard from the classroom or Eric, burnout secondary to unruly and ungrateful patients toward nurses and staff. And Ankit is saying an opportunity is to transform the delivery and practice of emergency medicine and healthcare in general. Limited resources. Damien, feel free to pause me in this reading if you wish.
No.
Moral distress, I'm hearing from Amanda, related to staffing shortages and being unable to provide the care we want to. Of course, this huge problem of loss of nursing from the classroom, and then Neil is suggesting mental and emotional health. So Damien, I think these are some of the things that are resonating for many of us, and maybe we'll pour into where you're going next.
Yeah, and
thank you all.
Seems like they're either practicing in Boston or they we're all in the same boat here. I think especially this last bit around mental health, which I think applies to the psychiatric boarding situation, at least that that we have a huge shortage of psychiatric beds, and so our patients are waiting and in our space, but also the toll on the clinicians. So we recognize this sort of early on during the COVID pandemic, and this is a bit of the story of how we got into really shifting our lens from, in addition to debriefing in a simulation-based context, because Jenny and I primary work has been at the Center for Medical Simulation, which is a independent nonprofit in the center of the Harvard system. Our kind of main thing is teaching and consulting. We serve our insurance company to decrease malpractice risk. We do international consulting. We do courses on debriefing. That's kind of our background, and just so you know kind of what we do. But during COVID, we said, look, our center is closed. We're interacting with people online, but what can we do now? And with a small group, interprofessional group over at the Brigham where I used to practice, we stood up a nightly debriefing program. We called it Brief. It was online every night at 9 p.m. And we really tried to get people connecting, interacting, discussing. And we also really served as the ears and eyes for the administrators who were working day and night to implement new protocols, to get feedback, to see what's working, what's not working, what's missing. And so we were doing this dual job of listening and connecting with each other, but also translating back what was happening in the day-to-day. And that was one of our first forays into this. Different impacts came about in terms of the clinical context, the provider experience, staffing and scheduling. With the volume being down, we were trying longer shifts, shorter shifts, and this gave a chance for people to both vent and be productively constructive. We got feedback on the protocols, and I think we strengthened our teamwork and collaboration because being an interprofessional discussion moment, we could learn about different angles which we wouldn't otherwise be privy, especially in the kind of masked PPE world. And we think for a lot of people, it served as a source of resilience. I'm not sure I would say wellness per se, because that's really more of a proactive mode, but in terms of being able to bounce back from difficult situations, because as I could only assume you experienced too, being in the front lines was pretty challenging, new, and traumatizing. At the Center for Medical Simulation, we also took to a bigger project, which is to create Circle Up, which is a larger workflow adaptation that takes a look at the whole shift and starts with briefings, has huddles, and end of shift debriefings and peer support. So really taking the idea that conversations can impact care delivery, and that if we structure them and make them routine, we can have an impact on our workplaces. And we'll have a bit more depth in terms of Circle Up, but I wanted to give both of those examples as both our lineage into how we got into the topic, and has, for me, it really made it the focus of my scholarly pursuits, and also our background there. So I think if we want to define success, you're thinking about implementing a clinical debriefing program. Shayla has met with Jenny and I a few times, and we really understand you're hoping to transform your work to really try to get at a lot of the problems you've highlighted in the chat and in your comments. We need to know what success looks like. And so to define that, I think we need to know what's the purpose. I think there's multiple purposes in terms of clinical debriefing, and I'll just highlight some of the ones that have come from the literature. You could think about debriefing's purpose as peer support, getting together to connect, reflect. I think there's an outcome of team cohesion, camaraderie, the relationship amongst you. So after you take care of a patient, that could be a big focus. Learning and learning to learn, I think it would be easy to just move on from a routine or challenging situation. I think normal across the world is to go to work, go home, come back, start over. And so a structured conversation could help us get learning from the everyday. By sharing and different perspectives, you get a chance to compare them. There's a real interest in clarifying events that I've seen from the OB literature, that when teams debrief before documenting after difficult deliveries, there's a much more protection because the inconsistency in the chart is a big risk. From assistance point of view, finding latent safety threats is a great opportunity, because we would hate to have the same source of error. That's why there's a relatively large investment in root cause analysis, but that's generally done down the line. And so getting to that earlier during the near misses could be an opportunity. I mentioned listening. Outsourcing listening to the debriefing was a big outcome for us. So providing feedback to leadership, and who doesn't like to let them know how it's going, right? And supporting just culture, psychological safety, and offering resources. Sometimes you just need a little encouragement from your colleagues.
Damien, could I just throw in one thing there, if you don't mind going back? We are writing up the results of a study we did in the neuroscience ICU in one of our hospitals here at Harvard. And I wanted to just share this idea of team cohesion, teaming, camaraderie, esprit de corps, because it sounds a little squishy. And one of our most robust findings from this routine debriefing intervention was people felt their emotions were kind of down-regulated in a good way, contained. They would save up things to talk about at the 10-minute end of day debriefing. And they reported to us that just knowing they were going to be getting together with people to do that made them feel better, made them feel more supported, relaxed them the rest of the day because they knew they didn't have to hold it metaphorically by themselves. And so that sense of togetherness is not just a kind of kumbaya-y thing. it really made a big difference for this team. And so that's the kind of thing we'll share more as we go forward.
So thank you, Jenny, for adding that specific example there. I think working definitions, and I really mean working because I think in one sense, we've been debriefing in the clinical environment forever, right? Like as a resident, we would certainly go to the bar back before COVID when that was a thing. And people would talk about their cases in a HIPAA compliant way. I know I'm married to an emergency physician, so we're always talking about cases and our experiences. But I think formalizing the practice of debriefing in the clinical environment is really of the last 7 years, and I think really coming to the front. And as passionate as we are about debriefing, I think debriefing has a bad name, just like feedback. You know, who wants to get called to an office and have a feedback conversation? I mean, generally people are not excited about that. And I think the similar could be happening about debriefing. So I think although we want to talk about debriefing in the clinical environment, I'm not sure that when we get to it on the day-to-day basis, that's the word we should be using. And so we've chosen circle up, because that seems to be a helpful, exciting thing to do. Whereas, in my current workplace, everybody's telling me, just whatever you do, don't call it huddles, because huddles have a bad name. In some other places, debriefing might have a good brand associated or a bad brand. You would know your own context. But in general, I think we're talking about conversations that occur in the clinical environment, meaning not in a simulation center, not in a teaching space, that look back towards what happened in a clinical shift or moment. And if you look at the literature, some of it is related to hot or cold debriefing, which is a metaphor for the emotional activation of the moment. So hot debriefings are thought to be right after an event where people are still all heated up about what happened, and cold would be later on processing. And I've argued that we should abandon this type of language because it doesn't contribute to improving the conversation. Clinical event debriefing is usually trigger-based. Systems that implement clinical event debriefing define the events, and they don't, I want to make it clear that they're not necessarily bad events or bad outcomes. You can have a routine event debriefing about any time more than, you require 2 passes for a successful intubation. That could trigger, maybe that's a quote bad outcome. Maybe you're defining every intubation. Maybe you're defining every time CPR is done. You could be defining, at BMC, we're now debriefing. One of the areas we are debriefing is every time restraints are applied or de-escalation of an aggressive patient. Again, going back to the mental health crisis. Real-time or proximal debriefing, I think this is more of a time-based notation. And that's what I would recommend in terms of how we're thinking about this. Frequently, if you don't get it done right away, it just won't happen. There's a lot of energy in terms of gathering people and a lot of other pressures in our clinical lives. And so really almost immediate debriefing after you take care of your patient, yourself, and you're ready is likely one of the most successful. Towards the end of the shift or routine debriefings, where you reflect on the whole scope of a work time period, that's another opportunity. And I think just like end of shift feedback, you want to incorporate that into the end time, but not after. So we want to incorporate this into work. And I want to contrast this with critical stress incident debriefing, which is a psychological technique to prevent PTSD. This is the work of trained psychologists, and that's not what we're talking about. And really, clinical debriefing excludes that and really is focused on team-based, peer-based conversations that don't require mental health professionals. Jenny, to you.
Okay, so folks, we're about to enter a little maybe 12-minute flow here together where I'm going to introduce you to Circle Up debriefings. And then I'm going to invite you in to help us do a little Circle Up debriefing. I'll explain a little more about that in a moment. And when I say invite you into it, I'll invite you to text to us or chat to us, whatever that might be. So Circle Up, the system of Circle Up peer connection and workflow adaptation includes the following. Damien, if you don't mind, click. So we have a briefing or a huddle, which allows us to either plan for the shift or plan for the event. So planning for an event like we have a COVID positive patient who's coming in for a C-section, that wouldn't be so much in the emergency department. Or today we're going to be transporting patient X. We know we're going to have several patients needing to go to CT. How do we transport a COVID positive patient from the emergency department to CT fast and safe? It also includes peer check-ins across the shift. How are we doing? How are people feeling? That could also happen after a clinical event. We'll talk about that in a moment. And then the debriefings themselves share successes and explore challenges for the day. Going back to the briefing for one moment, the idea of mental rehearsal, just thinking about what's coming up. So if we had a combative patient this shift, what is our plan? Who's involved? How are we going to handle that? Would be an example of mental rehearsal. All right, Damien. So to support you, for example, if you were thinking about implementing clinical event debriefings, we have some guidance and some scripts for Circle Up, and I'll be using that in a moment to guide the debriefing, sort of simulated debriefing that we'll be doing together in a second. But if you need this sort of cognitive aid and we think it's very helpful, these are available for your team. Okay, Damien, next slide, please. So what we're going to do now is you're going to join us in a little fiction, a little simulation. We're going to imagine that you are observers in the emergency department. Maybe you're walking by, maybe you're part of a team that Shayla organized to sort of help teams that are taking care of trauma patients to get better and to get better at getting better. So what I invite you to do in a moment is to imagine that I am that nurse that you see in front of you there, Mary, and Damien's twin, Damien, will be running this gunshot wound resuscitation. I say it's his twin because I've seen Damien run many resuscitations, and his twin has different skills than Damien does. After this, we're going to pause, and I'm going to step into the role of Mary. I'm going to put on my scrubs at that point, and I'm going to try my best to initiate a peer-led debriefing, and I'm going to invite you all to participate. That'll be clearer in a moment as to how that will happen. All right, any questions? Shayla or others from the classroom, or Eric Smith, who I also know has access to typing. Any questions? Or anybody? Okay, sounds good. Thank you. All right, Damien, let's play that video, please.
And I'm playing the first 2 minutes or so. Is that
right?
Okay?
Yep, that's perfect, Damien. Thank you.
Okay.
What's going on here?
We got a 23-year-old male, gunshot wound to the chest. Blood pressure is 100/60. Heart rate is 112. Respiratory rate is 28.
Has the trauma team been activated?
I don't think so.
Can you activate the
Yeah,
trauma
I'll
team
call them.
and also get the
Yeah.
ED physician?
Okay, yep,
No
on
more
it.
hanging, no meds given.
Great.
What do we have
We've
here?
got a
Hey, guys.
Am I throwing that all the way down there?
No family came on the ambulance with us.
We're at 110/60, 112.
Sir, what's your name?
28.
John.
Okay, the airways patent.
And where's my second ID?
What
Let's put a
happened?
second ID in here, please, and then, do you want labs?
Yeah, trauma labs.
Hey, Melissa.
Can you
Labs
be
will be
quiet
done
a
on this
little
side.
bit?
Pressure bag,
Can
can
you
you
be a
get a
little
pressure
quiet?
bag on that?
Oh, yeah, I can get the pressure bag.
Okay, there's no pressure on the left. I think the chest is set up for here, and we need 2 IVs.
Yep,
Let's
we have
recycle the
2.
pressure. Keep them on the
What labs do you
monitor. Start transfusing. The whole trauma set.
What do we got? Oh.
Okay, 23-year-old male, single left gunshot wound to the chest. Sorry, single gunshot wound to the left chest. His vital
I'm gonna
signs are
cycle
stable,
another
expected
blood
to
count.
reach
Okay.
55.
Oh, yeah.
We're putting in a chest tube for hemothorax on the left. Where's the chest tube set?
Got a chest tube.
I said I needed a left chest tube. Come on,
His
let's
blood
do it.
pressure's dropping, it's 80 over 60, his heart rate is up to 140.
ABCs, I told you, we got, we need a chest tube there. We're just undressing him, we're gonna roll him. And let's transfuse him. Where's the trauma cooler?
Let's not worry about, we can't,
Yeah,
can't
okay.
here, someone over here, so let's roll.
One leg, okay,
I'm
I'm
gonna
gonna count.
for this, isn't it?
Okay,
Count.
1, 2, 3.
Alright, we've got no exit wound, no exit wound.
Okay.
Okay,
And
down.
back,
Alright,
1,
back.
2.
Where's our blood? Kathy,
What's
where's
that?
our 4 units of cross-match blood? Kathy,
Okay, everybody. Hi, my name's Mary. I know many of you know me. I've worked in the emergency department for about 15 years. And I'm going to try to initiate a debriefing for us. You know, we just had that GSW, about 20 minutes ago, and I know we're trying to learn from what we're doing. So I'm going to take about 5 to 7 minutes and just invite you all in. And Damien is here with me, and I know, a lot of you are starting to do this debriefing too. So if you were, if you happen to see what was happening, we'd really love you to help me and Damien and the rest of the team get better. I'm going to use a script because I'm kind of new to this clinical debriefing process, and that's just to help us get through this. Damien, are you good to go?
Yeah, I'm settled my other patients, and I don't have a ton of time, but so great that that we're all here.
Okay, and the classroom and others, you guys good to go for 7 minutes-ish?
Yes.
Okay, excellent. So listen, we really want to hear from everybody. And our first goal is to kind of capture some successes and generate some ideas for improvement. I know there's always ways we could get better. So let's just start with, what went well, Damien, for you and for me, what did we see? And others of you, if there's anything you think the team did well that we should keep doing, if you could just let us know. Damien, how about you?
I mean, everyone getting called right away, I thought that was great. And getting the patient sorted out, I'm very happy about that.
Okay.
Positive.
Yeah. Other thoughts from people? Anything we should keep doing?
People move with a sense of urgency.
Oh, excellent. Thank you. Hey, yeah, that was great.
Like everyone jumped in.
Yep. Vital sign identification, activation of the trauma team. Yeah, I thought, Damien, just that reminds me, one thing I thought was great is you identified right away we needed that chest tube. So, that was good. Oh, yeah, people jumped into their roles. Excellent. So Damien, I know team leadership is something we've been working on over the last couple months, and anything you were happy with there that we want to just capture before we moved on? Staff seemed trained. That's great.
I mean, I think of leadership as something everyone does, not just the doc. So, the nurses, you and the whole team was really like bringing things in, doing a lot, really thinking about the patient. So there were a lot of good aspects of that.
Okay, good. Guys, I'm moving on because I know we only have, 3 or 4 more minutes. So let's talk about what we could do. Oh, sorry, Damien.
No, I mean, the trauma team did come down also really quick. I was surprised. Sometimes we're waiting a little more than that. So I was happy to see her there.
Yeah, Dr. Kate, that was great.
Yeah, and also, she came in and like kind of quiet and took a hand off. Sometimes it's been, people, they just come in like take over. So I thought this was collaborative.
Great. So Shayla, I know you're working with us to try to make sure we get things back up the system. So maybe a kind of props to the trauma team. Really appreciate their coming down so quickly. Okay, let's switch gears and talk a little bit about what we could do 1% better, 2% better, 5% better. I know we can always get better. So thoughts from the team on things that you'd like to see happening different? Damien, maybe I'll start with you, and then others of you, please chat to us or chime in.
Well, this is an area that I'm really struggling with, Mary. I was a bit frustrated on the, chest tube setup, and there's sort of two parts to it. One is I just know you guys know how to do trauma, and I thought you'd be like one step ahead of the patient or one step ahead of me, almost like I wouldn't have to like say, let's set up for a chest tube because they have a gunshot wound to the chest. Like, I'd rather open up those kids, have them by the bedside and be ready to do it. Than if we don't need it, fine, it's just a little waste of material. So,
Okay, so
we did-
1%, one thing is
Yeah.
as soon as you ask for it, so one of us could make sure to have it at the bedside, okay?
Yeah, and I think the other thing is like where I used to work, they just had the kits there in the resus room instead of having to get them. Like, that's an extra step maybe we don't need. Maybe we should we're a trauma center, level 2 trauma center. We should just have chest tubes on
Okay.
it with a knife on top. That way we're not looking for that when we really need it.
Great, and got some ideas from Neil here that we could have possibly been a little more systematic in how we work through things. And, like when you ordered the chest tube, closed loop communication, or when I didn't, as soon as I did realize it, I could have said, I'm getting it. So thanks for those ideas, Neil. I think we could beef that up. Yeah, and then I'm hearing more listening for the team leader directions. What would that look like, the classroom? Thoughts on what could we concretely do? How would you know we were listening? Just want to be really concrete here.
Head. Close loop.
Okay, all right, so acknowledge orders, etc. Okay, guys, I want to move on. We only have a minute or so left. So part of why we're doing this is, this has been a tough couple years, and, dealing with the patients we're dealing with now, and the workload, and the, short staffing. How's everybody doing? Damien, but also like observers, how are you guys holding up? Any things that seeing this trauma resus brings up for you about how you're doing? Anything we can do to support each other? So how are you doing, or things to support each other? Damien, I have to say, I really appreciate your willingness to do this. It makes me feel like good, like we're going to get better at doing things. So thanks for the time here.
I'm putting some stuff in the chat box from people who are talking back here.
Okay.
Great, we're listening.
Yeah, whenever I see interpersonal violence, like, I'm always interested, like, what's the address, like, what's the part of town where it's happening, and there's just like a real sad side of this. So I'm thinking a bit about that. The other thing is, Mary, like, I might have been snippy or like quick and maybe seemed frustrated initially, but I just want to say I like working with you guys. Like, I think we were doing the best we could, and I'm ready to like move on to the rest of the shift. And I hope that's like, not a sour spot if I stepped on anyone's toes or anything was awkward. It's just in the heat of the moment, and I'm open to getting better at that.
Okay, sounds good. So last thing, folks, let's just lasso up what were our items that we want to hand off to Shayla and the others who are. So I think we were thankful that the communication with trauma was quick and excellent. We want to figure out a way to have a chest tube right in the room and accessible. Anything else that anybody heard in terms of workflow adaptation or workflow keeping up the good things? Anybody want to throw in?
And that they came down quickly. That was good too.
Yeah. Oh yeah, blood bank presents with uncross matched blood. Okay, great. Okay, folks, listen, thanks for your time. I know we've got a busy shift. Everybody, see you later, and we'll keep trying to do these. Okay, this simulation is over. Just gonna rename myself here. All right. Folks, Damien, I think we can move on from this. I think they know there's a script available. Okay, folks, I'd like to shift gears for a moment and just talk about why conversations like this one we just had are important. And I'm going to introduce a quick a model, and then I'd like to ask for about 60 seconds of texting back to me about your take on what I'm saying and relating it to what we just did. So we have a theory in my field, organizational behavior, that is very robust and has been shown to play out. And that is, although we tend to think of the culture in our emergency department or our hospital or our medical school or our residency as fairly static, that static culture is constantly reinforced or transformed by every single small conversation we have every day. So Damien, if you don't mind clicking, the conversations that we have, one more, create the cultures that we live in. So every time that I invite someone to speak up and receive that speaking up with warmth and gratitude, I'm creating a culture that's more psychologically safe for speaking up. Every time I bark at someone when they give me some feedback or they try to help me by pointing something out, I might be reinforcing a culture of silencing and indirectness. So one more click, Damien. So this feedback loop of how conversation drives culture can be virtuous, opening conversations, supportive conversations, caring conversations can increase a caring culture and open culture. And then that open culture in turn creates more conversation of the same sort. So that's a virtuous cycle. Similarly, though, it can be vicious, and we all know that. We've been in those meetings where somebody silences someone else, or it's clear that if you actually say what you're really thinking, that's a dangerous thing for your career. That reinforces a culture of silencing and indirectness. The silencing of indirectness further suppresses conversation. So if I could just come to you all for 30 seconds, 60 seconds, what was your take on, albeit simulated, the possible impact of the type of conversation we just had, that little mini debriefing, on culture?
Thoughts? Anybody?
I think generally the advice, the critique was very well received, and so I think that would encourage people to continue to give those kind of comments for improvement.
And by the way, those of you who are dialing in not from the classroom, feel free to text to us.
Or unmute and blurt out.
Yeah, unmute, definitely. We'd love to hear from you.
Yeah.
The more that you can bring up failures, but opportunities for improvement and not have it come back at you that way, increases the next person's chance to do the same thing.
Yeah, so Jenny and Demian, we some couple of our residents and students here are talking about how you can see that circle just even in the scenario that you talked about, when the critique is well received and someone is able to talk about an opportunity from improvement, and that's received in a positive manner, that encourages people to be able to bring up problems. Because I think it's easy to shove things under the table because you're afraid of hurting someone's feelings. And in a heated moment, it may not come out right because you haven't really had the time to pick your words or pick your language. And I think that can be inhibitory. But if you know that people are going to take it the right way and not be offended, not be hurt, not be angry, you're more likely to work together kind of to brainstorm on how things can continue to improve as a system, which is kind of the angle that we all need to kind of get behind.
Wow, thank you. And thank you to the team in the classroom for that observation, because I think it shifts to really an important thing, which is it's not only about the debriefing, it's about the receiving of the feedback. And Damien, I think this supports some of the arguments you'll make shortly about just the importance of just getting started. All right, Damien, let's go ahead. if you don't mind. So I'd like to build on what you all said and just provide brief data to support this idea that conversation actually drives culture. So in research that I did with colleagues at MIT, we looked at a series of chemical processing and nuclear power plants. And what we found was that suppressing information about operations tended to create problems. This is a $16 million fire explosion in a petrochemical generating plant, no deaths, no injuries. But in the root cause analysis of this event, what was discovered was that the conversations were all about production and money making, and that conversations around culture, safety, tended to always be in the background. The RCA, the root cause analysis, made a difference, but this whole culture of this plant shifted when the plant manager at the next meeting, when presented proudly with the high production numbers of the month, said, okay, thanks, but what safety corners did we have to cut to meet those metrics? And from that day forth, combined with the root cause analysis, that shift in conversation caused a marked shift in approach to safety within the plant. Next slide, please, Damien. The second, yeah.
I'm enjoying this idea that the conversations that change culture are both on the ground amongst clinicians, but also when we're administrators and leaders talking with each other and with clinicians. So I think both of those are in the model.
Thank you, Damien, for acknowledging that shift of context. So the other thing I'd like to highlight is most of us in clinical medicine, academic medicine, nursing, interprofessional, have been socialized to be nice. So we are worried that if we have a critical insight, that's going to blow up badly, like this grenade here. And so we kind of try to decorate around the grenade with nice words and so on. Damien, if you don't mind clicking. So what we find is these hidden judgment conversations, hiding what I really think, even though I think it is helpful, actually reinforces a culture of, again, conveying that talking about errors is shameful rather than a beautiful opportunity to learn and get better, or an opportunity to change the culture to focus on getting better at getting better. And so this case study of ours looked at how that core dilemma of I want to help you, but I don't want to harm you, actually has this unintended consequence of degrading the culture of conversations. Click one more time, Damien, and go on, please. We can just go on. Then the last thing I'd like to highlight is the amazing, and at least for my career, and I think many of us in healthcare indirectly, work of Amy Edmondson and team from Harvard Business School on psychological safety. But what Amy's found is that how we invite feedback has a huge impact on the culture of learning to learn, the culture of getting better at getting better. She focused on what she called leader inclusiveness behaviors, which is I'm the team lead in a trauma resus. I'm the surgeon in a procedure in the OR. I'm the senior nurse. I'm the this person or that person. Inviting people's input. I might be missing something, let me know. Receiving that with warmth and graciousness, crucial to receive it well. However, what our research is starting to show is that in everyday practice, each one of us has the power to transform culture by inviting feedback, regardless of our status in the hierarchy. So that is another way that conversations open up a culture of learning from each other. And so that's the groundwork, that's the bedrock, that's the field into which these ideas that Damien is going to share with you now kind of get planted.
You have a couple more.
Oh, sorry, Damien. Somebody put in the chat that shit sandwich is a perfect example of that kind of silencing sort of culture. Oh, Damien, thank you. I forgot about these. So what we're trying to do here, folks, is move very simply from a culture where I'm catching you out, gotcha, and that has a lot of destructive impact, to a culture of where I've gotcha, I'm holding you, I'm here for you. And that's the shift that we think clinical event debriefing can help us with. Go ahead, Damien. Over to you.
I think, Jenny, you're helping us see how meaningful conversations can be, and debriefing it proposed as a potential new type of formalized conversation that's really would be a game changer in our work. And a colleague of ours at Brigham, when he was at Penn, studied debriefing rates of clinical events, critical events in anesthesia. So they considered triggers really truly critical events like failed airway, death on the OR table, unexpected ICU, massive transfusion protocol. Everybody agreed really that we should be debriefing those critical events and including their society, and yet only 49% of them were debriefed. And now we're really trying to move the needle in anesthesia to how can we get better at that. Interestingly, in his study, the ones that were the least debriefed were the ones that had to do with communication and interpersonal. So we're kind of a double problem because we're not only not debriefing enough of the critical events, we're also not debriefing the ones that are really intervenable. So this is my new shop, Boston Medical Center. We see about 110,000 a year. This is our old but nice resus bay. We have 3 of these and they're in constant flow. And I used to work in New York at Bellevue, and this was pretty typical, as I'm sure is of your resus room, the aftermath of a resuscitation. So this particular day, like in the video you saw, sick trauma patient, a lot of good care was given. It's not perfect. Like I always say, I'm from Argentina originally. So when you're dancing tango at a high level, you're going to step on each other's toes a little bit, but that's just because you're dancing fast. And so any other tango fans? Okay, you don't have to say. But once this event happens, I'm ready to need to do something. So there's some groundwork to getting started, really, and that's a personal in each of us. I know that immediately after an event, a resuscitation, an intubation, a argument with a patient, a family that leaves AMA, we've had increase in clinicians being assaulted. Really, you can really think about what's important in your context in terms of identifying targets for triggers for a debriefing, but they're important triggers such that immediately after, I'm not ready. I need to first get centered, get settled. I personally need to run my list. I've got 30 patients under my care. So I've just been involved in the event. So I need to make sure I know what else is going on. And then I move towards gathering the team. And in that moment, I'm also doing some of my own reflection and processing. And I think also getting into that mindset of, okay, I'm going to go try to gather the team, offer a 5 to 10 minute debriefing, and I'm going to acknowledge that we're busy. I'm going to do it with an effort to learn and listen more so than tell and correct. Even if in my initial impression, I was feeling like there was things that I wish would have gone differently, I'm really trying to reset myself to being open to other people's experiences. I'm going to help myself with a script because it's easy to get off track. And I'm going to go in for listening, for affirming, problem solving, and documenting. I think one of the most frustrating things is when you keep things in and don't share them. I think even more frustrating is when you share them and nothing happens. So for me, when I'm calling a debriefing or when I'm gathering people, I say, hey, I feel like I'm committed to getting people's ideas to the right place. And so I'm really going to document that and bring that to the post debriefing moments where I need to carry that information. But I'm going to do that with a spirit of confidentiality, right? So of course, it's not fully confidential, like everybody's going to know who was at that massive GI bleed or resuscitation. But when I communicate the findings, like it would have been better if the whole team arrived at once. I'm not going to say it would have been better if Jenny arrived early. So you're gonna translate the information that's gathered into actionable, helpful ideas. and it doesn't have to be I don't want you to think that that I think it's a sterile, stylized conversation. It doesn't have to be sitting around a table. It could be sitting around a computer. It could be in a conference room. It could be even in the dirty trauma bay while other people are tidying up and getting ready for the next one. In terms of the structure, I do think it's important to greet everyone and check in, because just because I'm ready to start doesn't mean everyone's ready to start. And I want to make sure for myself when I'm debriefing that connecting with people and seeing them is my primary focus, as opposed to getting the debriefing done. That's for me been a little bit of a mindset, just because I'm so passionate about having the conversations. I want to make sure I'm capturing successes and generate ideas for improvement, and I'm explicit about that. I want to make sure that is the prime goal, because I think, like I said, debriefing has a bad name, right? Debriefing is about learning. Debriefing is about feedback and critique, and it's really great. But in the moment after an event in the clinical setting where you were trying your best to help a patient, not everybody might be ready for that. I'm focused on supporting the team. And I want to, like I said, make sure I'm going to do the circle of action items, document them, activate follow-up roles and tasks.
Damien, I want to just say a word about the script really quickly.
Go for it.
Folks, you saw Mary's character use a script. It's a little mechanical, it's a little awkward, but I want to let you know that there's a wonderful research supporting the idea that scripts actually make people better. It makes them more comfortable, able to just even initiate the conversation, and peers are incredibly forgiving. They don't really give a bleep about the fact that the other peer is using a script. So it humanizes it, and I just encourage you to feel good about it.
And I think it also keeps me from some of like either old habits, bad habits, or habits from other conversation events, and so that would help. If you want some kind of extra language besides the top level, this is ideas from Chris Rusin, one of our colleagues at CMS. He's the Senior Director for International Programs and Education Leadership. He likes to say things like, look, we're going to succeed if everyone feels heard and respected, if we explore the successes and challenges. I like that scripting. In terms of supporting the conversations, he really asks people, how are they feeling right now? And I like that focused question because it allows people not to dwell on, he's not checking in on how did you think that went, or dwelling on what happened, but really checking in on right now, how are you doing? Because he wants to know that before moving on. And I like that a lot. Let's talk about difficult things that are happening. I think that's a really encouraging phrase that I'm trying to use. It takes a bit more courage, and just getting the conversation started is difficult enough in terms of getting people there. This is really taking it up one level, but if you're ready, I think that's a good one for you. So in summary, I think, in terms of debriefing in the ED, there's a mindset and self-prep. Don't underestimate that. Gathering the team with a humble offer. I'm not promising that this debriefing is going to change anyone's life, that it's going to, all of a sudden fix all the problems, but it's the micro conversations that affect culture. So I'm committed to having them as much as I can. And like you all say, I try to bring my learning self to them, so I can listen, support, and I can transfer, use my authority as a attending in the department, faculty member, to transfer, document for further action. But I think anyone can really take that role. You saw nurses. There's several papers describing nurse-led debriefings. There's in the anesthesia work we're doing with Alex Arriaga, it's the resident that's initiating. So we've seen different models for this. I think in terms, I got couple more slides, and then I think we're gonna let you know we're wrapping up towards a Q&A moment. So, one of the things in terms of getting started that I think has been really helpful for me came from the simulation literature, which a few years ago, I think this is 2017 already, Peter Diekman and others started to write about, let's learn from success, debriefing positive performance. And I think that's been a really helpful area for me to get started with debriefing in the clinical environment. Positive feedback or positive reinforcement is really so rare. And so you can just initiate a gathering, a quick debriefing, just to let people know how supported you felt or how well you thought it went, and to hear from other people. We used to say, oh, if you have a short amount of time, start with a plus delta debriefing. Now I'm saying, if you have a short amount of time, just start with a plus. Just getting together to talk about what's working is a good way to start. Don't have to do the shit sandwich. Don't have to do more than that. In terms of implementing clinical debriefings, I think one of the key things that is being done is to involve people from all levels of leadership, including leaders from the department, the debriefing program, but also all the clinicians from different professions. It's not the way you're gonna debrief in your environment is not gonna look the same when you're mature as when it started. Be willing to prototype, pilot, iterate. You certainly don't have to use the circle up script. There's other modes and methods that have been published, and they're easy to search, and getting started with one and seeing what fits. Definitely, I would recommend defining those triggers in advance so that you have a shared idea of when you're going to get together and for what purpose. And then name it creatively. If debriefing has a great reputation in your institution, call it debriefing. I mentioned, we're not calling it huddles. We're not sure exactly, but we know we want to find a name. At Brigham, we were doing brief. And that was a nice name because we made it clear that it was going to be short, and we had a cool acronym around that. Colleagues in Europe are using talk as their let's get together for a talk. Pretty straightforward. So I think cuddles that may work. Colleagues have also formally written tips about implementation, and I have to say I really agree with all of these, and you can access those. But a lot of their tips have been embedded into our comments here. And we hope that describing a bit of the how-to has come through for you. And we really thank you so much for sticking with us through the presentation and for your participation. We really hope you both enjoyed and got something out of that. And would love to turn it now towards your reactions, your comments, and any feedback. Jenny and I are always ready to learn. So, Shayla, thank you so much to you and the organizing committee for the invitation, and take it to you to organize here for the next 4 or 5 minutes.
Amy, you
Yeah,
want to stop sharing, and maybe we can invite people to turn on their cameras if they can safely do so. Go ahead, Shayla.
yeah, guys, do you guys have anything that you want to bring up, something, and a debriefing that you witnessed? We don't have a formal program here, is what I should say. And some moments are happening either informally or, a handful of us have debriefed intermittently when we've had time because we feel comfortable doing so. And so does anybody want to share any moments, some positive moments from debriefing that they've seen or experienced, or is anything else?
I have a different question.
Oh.
So I have a little bit of education within organizational leadership, specifically in the biosciences. My question is, I feel like it's always been this debate, do you end on a good note or do you end with change? And I think it's one of those things that was touched on a few times. It seems like your structure is more like end with something that we can change, something we can improve on, something like that. But I guess it's more of a question. Have you found anything that one is more beneficial than the other? And if so, I'm assuming that it's end on a note of change from the way it was set up, or it's just, one of those things that depends on the situation and going forward.
Amy, you want me to take a quick sentence swing on that and hand it to you?
Sure. I'm not
Yeah.
sure if I have necessarily looked at it, but I have one idea.
If what we care most about is behavioral change and or organizational change, setting a clear goal and commitment has been shown to improve that. So those personal improvement goals, or as a collective, we're going to focus on this. So if that's your main goal, then that's a good thing to end on. If you're trying to focus on cohesion and psychological protection and support, I haven't seen any evidence that it matters that that's the last thing that happens. I do think it's important that it happen at some point. And so thank you for your great question.
I think,
I could just say from practical experience, if you start with the negatives, the whole tone, like the what could be changed, the whole tone turns towards critique, and you have I have a hard time getting back to, but what worked well. And I really do care about that celebration in our management of the aggressive behavior patient. One of the key outcomes for me is that no one got hurt, patients or staff. And so I want to celebrate that early on. And that's giving us the reason to debrief, is to make sure we've checked in on each other and that no one got hurt. My second thing is, at the end of the debriefing, when I'm recapping, okay, so these are the 4 system level things I'm going to transmit. It may seem kind of a transactional, action oriented moment, but I think it's also doing a second thing, which is, I've heard you guys, what you said matters. And so I just don't want it to be misconstrued like we're just focused on the system improvement. I think it's giving the feedback that you've been heard.
yeah, I think it makes the conversation seem a little bit productive. And especially sometimes in those moments where a lot of stuff went badly, to have a silver lining on that, like, okay, well, we learned that we need to have X, Y, and Z in the department or in the code cart, and that's going to make this next crappy situation run more smoothly, and we're not going to feel so torn up about it.
How many times you meant to write a safety report but never got to it, and then you don't have the MR number or remember who was there, and it just never happened. So it's an opportunity.
Right. And I think we usually end by thanking everybody. So it's not like exactly a positive, but it just makes you appreciate everybody and give every person a moment where they feel valuable. And I think the tendency is, all of us here are either physicians or soon to be physicians, right? So we have an inherent position of power. No matter how nice you are, you're still that person, and it's going to be a little bit intimidating to some of the other team members, especially people who are like further down the pike, like PCAs and techs and all these other people who are doing the hard work, doing all the compressions the whole time for like an hour, and so they hear some feedback like, your compressions were really good, or maybe your compressions weren't that good in a moment, but you responded when I told you to pick up the pace, and it's really hard work, and we're so glad that because that made the difference in getting ROSC for that patient. And then letting them hear that, and then letting them be able to talk about, well, I actually sprained my elbow last week, be able to say that, right? Otherwise it kind of, makes everyone feel like there's sort of like the top of the pyramid and there's the bottom of the pyramid. So anything from attendings over here?
I struggle with is getting everybody together after. Everybody seems to just go. Everybody's got patients to check on, and so I find I'm doing it with the residents and not the other staff. We all kind of sit down after and talk about what went well, but trying to get other staff members, key staff members involved is a struggle.
I'm so glad you mentioned that, because I did skip that. I did start out with saying perfect is the enemy of good. If you can grab a few people, great. I think notice where you're doing it. If you guys have segregated desks and you're doing it at your desk, consider just moving to an empty trauma bay or doing it near the charge nurse station. I found even when I just get started with a crowd, people will gather and they want to know what are all these people talking about? And maybe just try to grab a couple of people from different professions first, as opposed to everybody. But keep it up, that you're talking with the residents, good.
Some kind of like procedure. Once we get the patient stabilized, we're like, all right, let's get them to the next destination. CT scanner, cath lab, ICU, you name it. Everybody's in work doing that, whether it's dropping an OG tube, dropping a Foley, but everybody still has jobs to do. And we go, well, we can do it afterwards. And then that afterwards turns into our next critical patient that walks in the door. And now it's flies on the wall and good luck gathering everyone. So if you don't do it immediately, it's probably not going to happen.
Yeah, so were you guys able to hear that?
Yep.
Yeah, and I think getting started in those in-between times, the CT scanner is a great time that, there's sometimes I have one nurse in there getting the monitors and the IV sorted, but they're going to come out eventually. And it's going to take a while you're looking for those early images. I think you can get started. That's a good opportunity. I think also, like I said, and you're right, there's a risk that there's going to be the next critical patient. So that is a thing. One of the things Jenny mentioned about our work with the neuroscience ICU and with some of our end of shift debriefing is that you can also, especially if you have an intact team over the course of a shift, you could gather everyone towards the end of the shift as you're preparing for rounds to say, okay, let's spend 10 minutes looking at the whole shift. We've done several cases together. Let's talk about what was working, what was not, what could we pick out from each one of them, anything we need to communicate.
I had a rough pediatric seizure patient who wound up doing okay, but there were a lot of missteps with getting meds and things like that in a timely fashion. And so, once we got the patient kind of stabilized, I said, everybody was busy and stressed out. And I was like, listen, I want to have a talk about what happened. And but I know like we gotta arrange for transfer. We got a bunch of other people that are like waiting, other patients who've been just like waiting for us to finish with this critical patient. I was like, let's regroup in about 15 minutes. And we needed, I mean, the patient wasn't registered properly. So we needed registration, we needed pharmacy. So I sent messages out to all those people and said, listen, we're planning on having a group discussion in about 15 minutes, just so we can talk about what happened, figure out what went well and what kind of things we want to improve for next time. If you guys are available, we want everybody on board. I promise won't be very long. And so we kind of did that where we're like, listen, it's busy now, but this is important and we're going to try to carve out a moment when we get caught up. So.
Well,
I was just in Boston and Burr, it's cold up there, but thank you so much for this conversation and getting it started. And for the interns, I think that this is an awesome opportunity for a collaborative quality project between us, nursing, and implementation in the emergency department. So I pose that as one option to you for the quality projects as we move forward. And I think we could probably get some great information from both of our fabulous speakers to help that process get started.
I'll just say something really quickly and simply. One single small thing that might come up at the end of a debriefing, like let's make sure we have the chest tube in this space, or let's make sure we have a hypothermia kit, everything's collected together. Actually making that happen, communicating to the right people, causing the changes is a thing. And let's people who are doing quality and safety learn what are all the different steps, what are all the relationships. So I think it's a great idea.
and let us know how it goes. So
I spelled it right this time.
Interested in those outcomes. So thank
Damien,
you, everyone.
you've got the cuddles committee now, Damien.
Yeah, it's a win.
Okay.
Tweet it out. Wonderful. Well, thank you, Shayla. Let's be in touch. Thank you again.